Hi, everybody. This is Sarah Brinkman, and I am a program specialist with the National Rural Health Resource Center. I'll be serving as the facilitator for this course and working very closely with Becky and our instructor, John, to ensure that your team is able to get as much as possible out of this opportunity. This training is made possible and available through funding from the Health Resources and Services Administration's Federal Office of Rural Health Policy and is being coordinated by the National Rural Health Resource Center, which is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. As the nation's leading technical assistance and knowledge center in rural health, the center focuses on 5 core areas, which include transition to value and population health, collaboration and partnership, performance improvement, health information technology, and workforce. And here we have a nice photo of a recent photo of our staff, which is near our office, and we're located on Lake Superior in Duluth, Minnesota. If any of you have ever been to Duluth, we have a famous lift bridge, and I don't think you could possibly get any closer to it than our office is. So just a little bit about the course. As most of you are aware, your facility was one of 30 randomly selected to take part in this training from more than 115 applicants nationwide. And we're really excited that you're here, and we look forward to learning from your experience as well. Some simple course expectations include that we want you to have fun and learn. This training is for you, and you will get out of it what you put into it. We hope that your team has fun learning about lean and is able to make some strides towards performance improvement in your hospital as a result. And on that note, we also encourage you to provide us with feedback and suggestions along the way for things that you believe would enhance your experience and increase your capacity to adopt lean. We'd like you to participate. The participation takes a number of forms in this training. There's attendance at the webinars, participation in the polls and the facilitated discussion that are a part of these webinar calls, completion and submission of the group exercises, making use of the Moodle forum, which Becky just showed us, participating in the one-on-one TA calls with John that will be scheduled in April, and other ways that we find to interact with one another. So we hope that all of those different avenues will enhance your experience on this course. And finally, completing the final project and submitting your final report. Again, we want to learn from you, and the best way for us to do that is for you to share your experience with us. There will be much more to come on the project and the final report as the course gets underway, and the final webinar in July provides us an opportunity for all of you to share your project outcomes with one another. We strongly encourage you to use Moodle as your main form of communication with each other and with us throughout the course so that everyone can learn from your questions, comments, and ideas. If you should need to reach out individually, you can look at the contact info that's provided for John, Becky, and I in the welcome section of the Moodle course. If you're interested in learning more about Becky or I, or to learn more about the services and resources available through the National Rural Health Resource Center, we encourage you to check out our website, which is linked here at ruralcenter.org. So with that, we're ready to get started. As Becky indicated earlier, today's webinar is being recorded, and the recording will be posted to Moodle within 24 hours. And then a shortened version will be posted as a public resource on our website once the course is completed in July. So again, my name is Sarah Brinkman, and I work at the National Rural Health Resource Center. I'm very excited to welcome you all to the first webinar of the 2016 SHIP Lean Training and Mini Project. I'll be jumping in a few times throughout the presentation today with some poll questions and then facilitating a discussion towards the end of our time together. But now I would like to introduce our instructor for this course, John Roberts. John is the CEO and president of Midwest Health Consultants. He has an extensive background in successful lean implementation and over 35 years of professional healthcare experience. John received his Lean Healthcare Black Belt in 2009 and serves as a lean coach, supporting clients through the implementation of lean concepts and tools in healthcare settings. Over the past 5 years, John has worked with multiple rural hospitals throughout Nebraska implementing lean concepts, and this is the 3rd time John is leading the SHIP Lean Training and Mini Project course. So we'll turn things over to John.
Thank you, Sarah, and welcome everybody to our first Lean training seminar. I'd just like to take just a short time to introduce myself. We're in Lincoln, Nebraska, and we've worked with, as Sarah mentioned, quite a few critical access hospitals across the Midwest and looking at lean and lean thinking, and we hope to share some of the things we've learned with you. And we've really designed this webinar and the SHIP training for small rural hospitals and for critical access hospitals. Today's agenda for the webinar: we're going to take a look at the challenges to the healthcare system that you guys are facing. I think that's important to take just a few minutes to really look at the why for why we're looking at lean and lean thinking and trying to implement some of the concepts. I think if you don't have a clear why as to why you're doing lean, you will not sustain it over time. And we've learned that through many of the organizations that we've worked with over the last 4 or 5 years. If they don't have a clear why as to what they're expecting out of lean and what they want to get out of it, as you'll see and as we'll talk about as we go through it over the next 3 webinars, you'll hear my passion for lean because I know what it's done and I know what it can do for your facility. So I'm really passionate about it, really excited that we're going on this journey together to learn more about it and to get you hopefully enthused about it so that you'll take it back to your facility and implement it. But I know from working with the facilities that I've worked with that lean thinking is not a quick fix. It takes a lot of hard work, it takes a culture change, and it's not easy. And so if you really don't understand why we feel like it's really needed in our institutions today, I think it'll, again, not be sustainable over time. So we want to take a little time to really look at that. We're going to give you some of the basic principles of lean healthcare. And again, we'll give you some of the basic tenets that kind of differentiate why lean is different than some of the other performance improvement tools that you might be using or that you might have heard about. A considerable amount of our time this afternoon is going to be talking about the 8 areas of waste in healthcare, and it'll prime you for what Sarah and Becky talked about earlier, about your exercise. That will be the waste walks that we're going to have you do over the next couple of weeks. Then finally, we're going to, my portion of it, we'll talk about an important concept in lean and lean thinking, and that is the voice of the customer, and really looking at what that means when we're thinking about lean and we're thinking about the methodology that we'll talk more about today. So let's talk a little bit about the why. From my perspective, I just think there's no doubt in anybody's mind that we're going through a fundamental change in the healthcare delivery system across the United States. We've seen, as probably most of you know, we've seen more hospitals, rural hospitals, close in the last 18 months than we have in the last decade. And again, it's, I think, attributable to this fundamental change that we're going through. We're certainly looking at what I believe is moving to a value-based purchasing system. And when we make that move, we're really looking at several different tenets, and that can be value-based purchasing can look several different ways and come in several different models. But the main thing that we're all looking for in this change to the healthcare system is more efficiency, more bang for the buck, more value. And so efficiency really matters to both consumers and payers. It certainly matters to CMS and the government. And so efficiency and creating value for what we provide is becoming more and more paramount. And we know clinical integration is going to be a key part of this new delivery model. So why is the healthcare system going through this big change? It's really, in my mind, not politics that's driving the reform. It's really the fact that we have a healthcare system across the United States that's unsustainable over time. As you can see from the slide that we have up, healthcare insurance premiums continue to rise. Workers' earnings are there towards the bottom. And again, overall inflation is much lower than healthcare costs have been increasing over the last 10 to 15 years. So our national healthcare expenditures per capita keep increasing, and again, I think all indications are of the research and everything you look at is that we can't sustain this level of growth over the next 10 to 15 or even 20 years. So we've got to look at ways to be able to change that. And I think you're all familiar with the fact that the United States spends twice as much per capita in healthcare than any other industrialized country. And yet our healthcare outcomes rankings continue to drop over the last 5 to 6 years. So there's, when people look at the healthcare system, and certainly the politicians look at this, they look at the fact that we're spending more than any other country, and yet the outcomes, healthcare outcomes that we're trying to produce are falling behind. So the bottom line is that we have to bend the healthcare cost curve. We have to look at ways we can begin to slow down this rate of growth in the healthcare system. And in front of you, we've put together the fact that on the red line, if there's no decrease in healthcare cost, you can see the red line will continue to grow. If we could bend that healthcare cost curve by even 1 percentage point over time, or 2 percentage points over time, you can see what drastic change that can happen over the next 20 to 30 years. So we're really, that's the basis of what we're looking at, and why we're looking at these new models and looking at healthcare reform. And the healthcare reform, again, is bringing new paradigms to our system and to the providers across the country. And I've just listed here some various ways that those new paradigms are being shifted. The primary care medical homes, we're looking at, again, pay-per-performance, value-based purchasing. We've got a lot of activity with accountable care organizations. And again, this is all in a result to try to look at how we can create more value and how we can bend that cost curve. And again, CMS and Medicare is continuing to look at ways they can change the delivery model and how care is delivered and how it's reimbursed. And again, it all goes back to becoming more efficient and providing a greater value for the healthcare expenditures that we provide across the country. So I think the bottom line is that we're in this big change, and as we talked about earlier, efficiency and value become very critical. And again, we have to be able to solve this problem with the integration of clinical services. And again, the really, in my mind, is really there is no plan B. We have to be able to come up with a redesign of our system, and again, try to bend that cost curve over time. In a recent testimony at a hearing at U.S. Congress, it was noted that about $2.5 trillion of the $2.5 trillion spent in healthcare, that we had a significant percentage that did not add value to patients. So I think, again, this is one of the things that lean and lean thinking helps us get to, is what is the waste in healthcare? How do we identify that? And I think there's a poll question right after this.
That's right. So the question is, what do you expect the percentage of non-value added expense is or was? So if you could take a moment to answer that question there on the screen. Do you believe that it was 7 to 10%, 15 to 25%, 30 to 50%, or 55 to 75%? And it looks like things are slowing down a little bit. So we have 16 respondents, or 57% of respondents believe that it was 30 to 50%, 35% believe it was 55 to 75%, and 6 or 7% of respondents believe 15 to 25%.
Well, I've got a very sharp crew here on the webinar today. Most of you are exactly right. The answer is somewhere between 30 to 50% of the healthcare dollars that we spend in the United States really don't add value or don't improve the outcome for our patients. And if this figure is anywhere close to correct, which I truly believe it is, there's huge opportunity for us as providers to be able to make improvements to what we're doing and providing to our customers and our patients. You know, when you think about healthcare, it's really not much different than anything that you would go out and buy as a consumer yourself. So when you're looking at buying a product or a service, what are the things that you look for when you're buying that product or service? We look at things like price, on-time delivery, what kind of quality is it, what kind of customer service or service after we buy the product or service will we get. And that concept is really no different for healthcare. We've not had as much participation, probably, because of insurance, of supply and demand through purchasing healthcare. But I think that's consistently going to change as the baby boomers come up and really look at how they want care delivered. And again, this change in the marketplace, this consumer-driven healthcare, they're all looking for value. They want to make sure that the dollars that they're spending for healthcare services, they're getting the best value for their dollar. And we know with studies across the United States that there's a wide variety and variation of what the healthcare outcomes are and what the cost is for a particular service. So we know there's considerable variation across the country. And again, consumers, businesses, insurance companies, they're all looking for value out of our healthcare system. So again, our patients are really looking for, and I think that's why lean becomes so important, is that lean is really, in the performance improvement tools, one of the only ones that really looks at how do we gain efficiencies through this process? How can we reduce waste that doesn't add value to our patients? And again, that's what our patients expect from us. They expect that balance of price, availability, quality, and service. So I really believe, truly, and what I tell our clients is that I believe the answer must come from us, that we have to look within the American healthcare system and make changes to try to bend that healthcare cost curve and make this this industry more sustainable over time. And again, that takes a lot of hard work. It takes a commitment on behalf of our providers to be able to do that. And it takes a real culture change in looking at how do we continuously look at providing the best value, demonstrating that value, and being able to show that we have good healthcare outcomes. So in my mind, the transformation for where we're going is really not optional. We know that the healthcare system needs to be easier, better, faster, and we have to create more value in our system. So we'll start with our next poll question.
Yeah, so now we would like to know, is your hospital actively involved in lean? And your answer choices are yes, we have lean embedded in our culture. Somewhat, we've been trained in lean or implemented projects, but we're not as lean as we'd like to be. Or no, this is our first exposure to lean training. And obviously there's no right or wrong answer. We're just interested in knowing what your experience has been so far so we have an idea of the makeup of the participants. And it looks like we have just a little over half of folks say somewhat, so they have some experience and have been trained in lean or have done some projects, but they're not as lean as they'd like to be. And a little under half say that this is actually their first exposure to lean training. We don't have anyone who believes that they have lean embedded in their culture yet, but I'm sure by the end of the training, people will be well on their way.
Well, thank you, Becky. Interesting poll. That's good to see. I think I'm glad that some of you have had some exposure to it, and those who haven't, hopefully we're going to give you that exposure to be able to take a look at lean and what lean can provide to your facility. I think the bottom line is that lean is going to be a survival imperative for our facilities, that those facilities who cannot make the transformation to becoming more efficient and providing more valuable will have a difficult time as we move into whatever this healthcare system looks like into the future. And so I want to make just a couple of points about why I think lean is imperative for our future success, particularly in rural facilities. One of the things is that I want to make the differentiation between cost-cutting and efficiency gains, and they're not the same. We've suffered through many of cost-cutting initiatives over the last 20 years. When we look at PPS, when we look at other types of changes in reimbursements, those are all for trying to cut costs by the federal government or other providers. That's not the same that we're looking for when we talk about lean and gaining efficiency throughout the system. We're looking at, again, gaining that efficiency and not hopefully having to do cost cutting, but gaining more efficiency and more value in what resources we're already using. So when we look at lean, it goes on beyond that basic cost cutting exercise that we do or have done in the past, and really looks at how do we create a culture that's focused on, one, waste elimination, and we're going to talk about some of those waste and identify those wastes. And the second one really is operational excellence. How do we look at what we do, what processes we have, and how can we make those better by eliminating what's not valuable to our patients and maximizing what is valuable to our patients. The key is process improvement. And when we're looking at lean and lean concepts, it's really focusing in on the process. And again, we'll take a look at some of the tenets of that process improvement. So what is lean? What is lean in healthcare? It's really a combination of two different things, and I want to hopefully highlight this, that it's more than the tools that you're going to learn about. And lean has a lot of different tools that you can use for different process improvement initiatives. It's really a combination of looking at those tools and using those tools and applying them in the best manner, but it's also a philosophy and a mindset that begins to align our processes with our environment, making sure we're matching value with what our customers want, eliminating waste, and really looking at continuous quality improvement by everyone throughout the facility. You know, too many times I think in some of our quality initiatives that we forget about the frontline people, and those are really the people we focus on in lean because they're the ones closest to the work that can really look at and improve that process because they do it every day. And so we want to look at the 5 overriding lean principles. And number 1 is we want to identify value from the customer's perspective. We'll talk about this a little bit more in the voice of the customer, but again, the basic idea here is really focusing in on what is value to our patients. What would they be willing to pay for? And quite frankly, in many of our facilities and organizations, we've designed our processes not for the value of our patients, but for ourselves, our providers. And again, one of the major tenets and focuses of lean is, again, looking at everything from the viewpoint of our customers. The second major principle is mapping the flow of the product or service. We're going to be looking later on in the webinar about flow and how that works through our hospitals, looking at value stream mapping. Again, looking at how things move from the time a patient is admitted to the time they're discharged, and how we make that flow through the process in our organization. Again, we want to look at that product or service and make sure there's no bottlenecks. We want that flow of service or product to be unhindered. We want it to add value. And so that's the third major tenet of lean. Then we want to create a pull system based on customer demand. We won't have a lot of time to get into that today, but there's a concept in lean that we talk a lot about, and that is push versus pull. And again, when you push things into a value stream, many times you'll get some of the waste that we're going to talk about. You'll get overproduction, or you'll get other types of waste. So what we want to try to do, the concept of pull, is to pull things in to the value stream when the patient needs them, exactly on time, at the right quantity, etc. Then the final concept is really a concept of continuously looking at ways to improve. And we'll talk more in the webinars to come about a concept called Kaizen, but that's really what we're talking about, is looking at continuously improving what we do each and every day, and that everybody throughout our organization is responsible for that improvement each and every day. So just to flesh out a little more of these principles, again, we're looking at value, specifying value from the standpoint of the customer or patient in this case. We're looking at the value stream. We're looking at what are the steps in the process, which ones are value added, which ones are non-value added. We want to look at flow. We're trying to keep that process, that flow of our processes smoothly throughout the process in our facilities. Again, pull concept is we don't push work into the next step of the process, but we let things be pulled into the process as they're needed. And then the final one, again, is perfection, that continuous pursuit of perfection and looking at small continuous improvements over time. I'm not going to go into a lot of background about lean on this webinar. You can certainly do that on your own. I just want to mention that many of the concepts were developed in the 1970s through the Toyota Motor Corporation. And that's where it has really many of its roots. When Toyota Motor Corporation worked with Deming to improve their processes and quality outcomes, that's where many of the lean concepts came from, even though at that time they were not called lean. That really didn't happen until in the late 2000s, early where they really began to take a lot of these terms and call them lean concepts. So that's why you'll see a lot of the lean terms are going to be Japanese. Like I mentioned, Kaizen, Kanban, Ujinka. These are all names, and so just so you have a little background as to where they come from. Again, many of them were developed through the workings of the Toyota Motor Corporation. One of the reasons I'm really excited about lean is that I know it works. I've seen it work. these are some of the results we've gotten from some of the facilities that I've worked with. It's not unusual to get anywhere between 25 to 50% reductions in labor cost, in reductions in wait times or turnaround times for certain tests. So I know that when it's properly implemented and when organizations have a commitment to lean, that it does work. So how are costs affected by lean? You know, we've, in a lot of the lean initiatives that I've been involved with, we've been able to reduce the cost of the care. We've been able to improve the reliability and safety and increase the quality at the same time. So it's not an either-or type of situation. It's really a situation that if it's done correctly, we can have a win-win. We can reduce the cost of the care, we can make it more efficient, create better value, at the same time reduce our cost and improve the quality of the care that we're providing. So you're probably asking at this point, you know, if lean is so great, why isn't every organization using it? And I think that's a great question. I think it stems from several different things. One is that a lot of hospitals that I've worked with feel like they're unique, that their patients are different than other facilities, and so they're not too sure that lean will work with their particular patient population. Other people talk to me and say, you know, it comes from manufacturing. We're not putting cars off the assembly line. We have patients who have variations in their condition and their diagnoses. So we're different. And while all of that is true, I still believe and know that lean can work in every organization, and it really can provide the results that you're looking for. I tell folks that are looking at lean, I say, you know, one of the key success factors that we've learned over time is that senior leadership has to be on board and has to be committed to implementing the lean process and the lean thinking across the board. Without that, we know that, again, it's not sustainable over time, that we get organizations with a good start and then it tails back to what they're more familiar with and what they're used to. So having senior leadership is critical to implementing lean. The other thing is that it's really a top-down support, but it's a bottoms-up grassroots approach that really gets the results in implementing lean and lean thinking. We have to really engage those frontline staff in what lean is and the tools that they can use and be able to implement lean from that level. The organizations that really do those two things really are the most successful that I've seen. So lean requires that everyone, again, looks at these new tools and techniques, and they develop new processes and procedures. They have a perception of what value is and how to measure that. I will say, and we'll get into this in the subsequent webinars, that measuring lean is probably one of the most difficult parts of the implementation of it, is making sure that the changes we're making are getting the results we want and to be able to measure that. There's a whole host of lean tools that you're going to hear about. We won't be able in this webinar series and to be able to go through all of them, but just to give you some samples of what many of the tools are from the Lean Toolbox. You know, there's just a lot of different tools that we can use for different quality or process improvement that we're trying to do. Some of the main ones that you'll hear us talking about are value stream mapping, We're going to cover that in the subsequent webinars. A3 problem solving, 5S, which is a worksite organizational tool. Standard work is another critical tool that we use. And then you can, again, see some of the other tools there, the Kaizen events, the mistake proofing, the root cause analysis. From my experience in working with small rural hospitals, the good news is that if you, I think, really focus in on value stream mapping, A3 problem solving, 5S worksite organization, and standard work, that those 4 tools will help you solve probably 80 to 85% of the problems that you're going to face. So I know sometimes lean can be overwhelming to folks, and thinking about how am I going to learn about all these different tools and be able to use them efficiently. Hopefully we can, over the next several months, reduce the anxiety there and help you focus in on the tools I think will help you the most as you move forward. So our next topic is really looking at the 8 areas of waste in healthcare. And our goal is to really help you see things with new eyes. And I think as you go through this webinar and as you do your waste walks over the next few weeks, I can almost guarantee you that you'll look at the hospital in a completely different way than you have right now. So with that, let's take a poll question.
All right. So before we kick off the discussion about the forms of waste, we just want you to think kind of almost like a pre-test sort of thing, to think about what you think accounts for the biggest form of waste in your facility. Is it money, time, space, or human resources? And these are not the only forms of waste, but just some forms of waste that come to mind kind of immediately when you think about them. So far, time's got it in the bag. Some human resources. Just give folks a few more seconds here to participate in the poll. Well, I think time is the clear winner here. We've got we've got some space coming up, but over 85% of participants believe that time is the biggest form of waste in their facility. Space and human resources are coming in tied at second for at 6%. Money, interestingly, didn't get any votes.
Well, I think these folks are right on target, and we'll look at these as we go through looking at each of the 8 different types of waste. But I think you're onto something. That the time is a critical element, and you'll see in a lot of these different wastes. Again, one of the primary focuses of lean and lean thinking and the methodology and tools we use in this particular process, one of the primary focuses is identifying and eliminating waste. And again, that's what makes lean different than some of the other performance improvement tools. Again, while we're looking at improving quality and we're looking at improving other types of systems, we're also wanting to make sure that we're eliminating waste and creating more value for our patients. So how do we define waste? Anything that adds cost or time that doesn't add value to our primary customer, which in our case is a patient, is considered waste. And you'll hear, again, the Japanese word for waste is called muda. So again, we're looking at anything in our processes that won't provide value to our patient and identifying those things. One of the, I think, a good way to remember the 8 different kinds of waste is what acronym we call downtime. And we'll go through these individually, but as you can see, downtime would stand for defects, overproduction, waiting, not utilizing people's talents, transportation, inventory, motion, and excess processing. Those are the 8 different types of waste that we'll see in your facilities and in the healthcare system. So one good question to ask yourself is, how does waste really affect me? And I think you'll be amazed that when you get into looking at your waste walks and identifying the waste, how much it does affect you on an individual basis and people in your organization. The waste causes physical fatigue. It causes emotional fatigue. I don't know too many places that I've worked in where there hasn't been frustrations in working and stress. And those kinds of things cause us to blame other people. And really, as you indicated in the poll correctly, is that it steals much of your time. And again, we want to reallocate that time to things that really provide value to our patients. One of the challenges that we face when we look at waste in our facilities, in our organizations, is that we have to have the courage to see waste for what it is. And why do I say that? Because the facilities that I've worked with is that this can be a very emotional issue in identifying waste. And why is that? It's because waste many times hides itself as work. It's difficult to go up to a staff person and say, we're looking at this process, and in this process we've identified that 40% of the steps do not add value. And that person becomes very emotional and can talk about things like, you mean what I've been doing has been a waste of time over the last so many years? Or they get really protective and say, you're accusing me of not being efficient. And again, so it takes real courage to be able to identify and call waste what it is. And I don't want you to underestimate the emotional component of that as you begin to take your lean journey. When we categorize waste, we look at it from 3 different perspectives. We call the first perspective value-added work. This is anything that our patients would be willing to pay for. That adds value to what their outcomes would be in getting our services. The second category is what we call non-value added but required work. This is any kind of work that would be required for government regulations or compliance that really may not add value to our patients, but it's required of us to be able to be in compliance with rules and regulations. And then the final category is just non-value added work, which is, again, any activity or time or resources that doesn't add value to our patient. So what we try to accomplish in Lean is really looking at how do we maximize the value added work, how do we minimize the non-value added work, and how do we eliminate these non-value work. So that's really what we're trying to accomplish in Lean. So let's take a look at our first waste, and that is the waste of overproduction. It really is doing anything that is needed by a patient that's not needed, or doing it faster than is anticipated, or pushing it into the next step of the process. So let's take a look at some examples of overproduction. Again, making more than that's required in a process, making it earlier or faster than is required. And some examples may be medications given out too early, or maybe a lack of communication on what needs to be done, or duplication of testing. Other examples of overproduction can be duplicate charting, multiple forms with the same types of information, copies of reports sent automatically, whether the person in the next queue in the process really needs them or not. So those would all be examples of overproduction. Overproduction is probably one of the leading causes of waste in our organization. And really overproduction can lead to a lot of the other waste that we'll talk about here in just a few seconds. Really poor communication between departments can be a clear signal of overproduction, and really no clear specification on who needs what at what time can also be a great indicator of overproduction. The next waste is the waste of inventory. Anytime we have more excess inventory, cost, storage, movement, spoilage, that's an example of the waste of inventory. And again, examples can be supplies that go out of date, medications that go out of date, having more than we need in a particular area, having to move that from one place to another. So this gets fairly complicated when we're talking about central locations for inventory versus smaller amounts of inventory closer to the patient bedside. One of the unfortunate side effects of the waste of inventory is the problem of hoarding. And we see this a lot in the organizations that I work with. And it's really because what I call just-in-time thinking or just-in-case thinking. To give you an example, had a discussion with a nurse about why they had extra supplies of certain supplies and materials in an area of the hospital. And she relayed the story to me of one time that she didn't have what she needed, and she got chewed out by the attending physician, and she swore that she would never let that happen again. And I'm sure this is not an isolated case. And so, again, that just-in-case thinking really leads to packing away extra supplies and leads to the waste of inventory. The next waste is the waste of transportation. Any unnecessary movement of patients or supplies or material in an organization leads to the waste of transportation. And again, this can be a significant waste in many of our hospitals because, again, we're looking at what's the distance between patients and the supplies and information we need, distance between departments, how do we move patients throughout our organization in the most effective manner. So some examples of waste of transportation can be moving the same patient multiple times, or moving specimens or supplies, any rework or defects. We have poor layouts or poor scheduling in many of our facilities, which makes it hard to overcome some of the transportation issues. The next waste is the waste of waiting. Anytime a patient has to wait, anytime an employee is waiting for something they need in the process to be able to do their job, that would be an example of the waste of waiting. And again, we kind of take waiting for granted in hospitals, and I think we need to take another look at really what that waste is and what impact it has on our patients and our customer satisfaction, et cetera. Some examples of waste of waiting is waiting for discharge or test results or certain approvals, equipment, people, all kinds of different kinds of examples of waste of waiting in our facilities. The next one is the waste of motion, and I will say that this is probably the largest waste that we work with many of our facilities and organizations. Really, people don't stop to think about how they move in doing their jobs throughout the day. And when they really begin to take a look at how they flow, how their work flows through their department or through their process in the, or step in the process, they really begin to look at how much wasted motion there is and how much time that really eats up in an organization. So when we look at examples for waste of motion, it can be, again, looking for patients, specimens, anything we don't have to do our job. Can be looking at going from going back and forth between getting supplies or moving a patient. It can be a lab layout that if we redesign the way the flow was for the laboratory, we could eliminate a lot of walking and extra motion in that process. And waste of motion also, as we talked about earlier, really contributes to fatigue. And again, when you're tired and you're fatigued, you're more likely to make errors and produce a lower quality of work. Just to give an example of this waste of motion, we worked with a facility and did some spaghetti mapping with the ER. And this was a little larger facility, and we used pedometers to measure how much a typical nurse was walking in a typical 12-hour shift. When we did our baseline study, that was about somewhere between 12 to 14 miles per day. And when we looked at redesigning the way they did their work and putting in new policy procedures and processes, we were able to reduce that back down to about 7, maybe 8 miles per day. So again, we get a 40% reduction in the waste of motion. And again, that has a significant impact on the staff and their ability to take care and provide value for their patient. The waste of rework, anything that is a defect, anything that happens not correctly the first time or must be repeated would be an example of the waste of rework. And we see many of those in our facilities. Some examples are medication errors, wrong site surgery, wrong patient information, missing information, incompatibility with software. I'm sure as you guys have gone through converting to electronic medical records, you found many of those defects and what you're trying to accomplish. The next waste is the waste of what we call excess processing or over-processing. Again, this would be anything that does not add value to the patient, that we've done more than it needs to be. And again, we can see a lot of examples of over-processing. This example that I'm showing you is a real example from a facility I worked with. It was a hospital admissions department routinely completed a form for each patient for day surgery and sent that document with the patient file. Why? Because they felt like the day surgery people needed it. And when we talked to the day surgery people, they said, no, we don't need that information. And again, it's just a breakdown in looking at what's required and taking a look at what information needs to be in certain places. And again, sometimes facilities use over-processing as a way of quality control. And again, this just adds more waste to the process. And there's certainly definitely better ways to have quality controls than some of the over-processing that we've seen. The last waste is not utilizing or underutilizing people's skills. When we have employees doing work that they weren't trained for, or we're not taking advantage of frontline staff, people's ideas on how they can improve the process and make things more valuable for our patients, that's an example of not the waste of not utilizing or underutilizing people's skills and abilities. Again, some of the ways we can identify that. So again, what we want in this process is for you to begin to increasingly see, hopefully, what you haven't been able to see before. And again, we'll talk more about this when we go in specifically to the waste walks. Again, your goal over the next couple of weeks will be to begin to build the skill, and it is a skill, of looking at how you can identify these 8 wastes in your facility. And like anything, the more you do it, the better you'll get at it. And so the exercise that we've got designed for you over the next couple of weeks is really to get you to start really shedding off the old ways of thinking and really looking at how you can see things through a different lens. And so again, we want you to look at the wasteful activities in your area and to look at those 8 different kinds of waste and try to begin to identify those in your facilities as we move forward over the next couple of weeks. And we'll get more into that here in the final discussion. But I want to go into one more topic real quickly because it's very critical to lean thinking and the basic principles of lean thinking. We've talked about it some here in the earlier discussions, but it really is, how do we capture the voice of the customer? We need to be able to capture both the stated and unstated requirements that our customers or our patients expect from us. And that's, while it seems straightforward, can be pretty difficult sometimes. But again, a major tenet of lean thinking is always viewing what we're doing from the perspective of the patient. So who is the voice of the customer? It's really the patient's family, the patient's physician. It can be a payer, regulatory agencies, and other caregivers. Those could all be considered a voice of the customer. And again, why do we want to find the expectations of what our patients are looking for from us? In lean thinking, it's really called critical to quality characteristics. We want to know exactly what they consider is valuable and how we can provide that to them as they go through our organizations. So let's take our next, I think, poll question. Oh, I jumped the gun here. Sorry about that. The customer is the principal judge of quality, and we have to know and understand that. And we, again, need to make sure that we build our relationships with our customers and our patients and understand what their needs are and what they consider to be valuable. Again, we don't have time to go into all the tools that we might use in capturing the voice of the customer, but here's some of the ones that are probably more utilized, and that is direct discussions or interviews, surveys that are closer to the time that they're actually in our facilities, focus groups, and we can use other things like customer complaints, observation. Again, we want a good mix of qualitative and quantitative methodologies to look at this.
Oh, here we go. Here's the poll question related to voice of the customer. So we're interested in hearing from you, which of the following methods, if any, is your facility currently using to capture the voice of the customer? And you can select more than one option and think about if your facility is intentionally using these methods to capture the voice of the customer. As John said, we don't have time to go into all of the details of all of the tools available, but we're interested to know what you're using so we might be able to tailor some of the future offerings as well. And not surprisingly, surveys are coming out on top. A lot of facilities are using surveys as a means for capturing feedback. Customer complaints are a way of gathering that feedback that we don't always necessarily even have control over. We just get them anyway. So it's whether you're using that information to be able to fuel real tangible change or just capturing it and not necessarily using it. Direct discussions or interviews at 37%, focus groups 15% of participants are using, 28% are using observation, which we're going to be talking about some more in the waste walks, and nobody indicated that they weren't doing anything, which is great.
Yeah, that is great to hear because, again, this is a central tenet principle of lean thinking is making sure that we're attentive to the voice of the customer. One tool that I want to just quickly go over is the Kano model. It's a tool that I use quite a bit with the organizations that I work with. The Kano model was developed by Dr. Mariago Kano quite a few years ago, but it really gives it's a model that gives us it's a two-dimensional model that uses performance versus value, and he has certain categories that he divides this model up into that I think are pretty helpful to us as we look at the voice of the customer. Some of those are what he calls must-be's. They're quality characteristics that have to be present or the customer is going to go someplace else. The next one is what sometimes is called performance. I like to call it more is better. The better we are at those things, the happier the customer is. After we've met their basic must-be needs, if we can provide that performance so that more is better, they're certainly happier customers. And the last one is what's called delighters. Those are things that customers didn't expect, but that when we delivered them just created a better experience for our patients. And so when you look at the Kano model, for instance, over different industries, for example, the airline industry, what might be a must-be? Probably safety. You don't ever get on an airplane thinking it's not going to be safe. What would be more is better or performance? Things like cheap tickets, if you can get a better price. And then what might be a delighter? In my case, a delighter is really a friendly staff that welcomes you on the airplane. For a hotel industry, what must-be's might be cleanliness. And more is better might be the award point program. And the delighter may be the warm cookies at night when you check in. So again, what would those be for a hospital? I challenge you to kind of take a look at that. What are the must-be's? What are the things that can get us better performance or more is better? And what things might delight our patients and customers as we move forward? Again, voice of the customer is critical to understand. For every patient complaining, there are 20 or more who do not complain but don't return. And again, we need to be able to understand what their expectations are, and we've got to be able to do that. I like the fact that you guys are using surveys, but I'd just offer one caveat to that. If you're using HCAPs to get your voice of the customer feedback through that tool, again, it's a great tool, and it's something that obviously we're going to be dealing with reimbursement as we move forward. But I would just caution you that many times I think of HCAPs as kind of driving a car while looking through the rearview mirror. And again, it can tell us what some of the downstream outcomes are for our patients, but I would encourage you that many of the things we're looking at in lean, the voice of the customer, are more upstream, more current, so that we can address those issues before they ever get hopefully to the HCAPS survey. I really think voice of the customer and being able to be good at that is going to be a competitive advantage for our facilities that do it well. And again, that's why we are so high on it with lean, is because we feel like it does, many of the tools help us to be able to